Great. Thanks so much, Jen, and thanks to the entire planning team for the invitation to spend some time with you today and to really host and hold space for today's conversation. Racism is the status quo in Canadian society as it is in other Western settler states and indeed globally. So I think the racism informs our histories. It informs the stories we tell ourselves of who we are. I think it's important for us to have a different remembering of Canada, a different remembering of Turtle Island. This space is the home to diverse First Peoples. Canada is the place where Black bodies were enslaved, Black and Indigenous bodies for that matter were enslaved. Canada is the place where Japanese Canadians were interned during the Second World War. It is the place where people who were deemed to be from an unsuitable race were excluded from entry into this country. Those are just smatterings of the histories which we are contended with during today's conversation. And I think what has become a cliche in the COVID pandemic bears saying, that COVID is exposing the cracks in our systems. These cracks, which are becoming hyper visible to folks, to a lot of Canadians, have always been very visible for Black, Indigenous, and people of color. Visible because these systems impact our lives in very profound ways. And I think what's happening is a bit of a consciousness in the folks of in the psyche of white folks, which I'm hoping is going to continue after life returns to a different version of normal, but after we start to re-engage in our daily lives, that we keep the memories of some of the inequities which we're all seeing right now in our minds, and really think about how we create a different kind of society, both within the health system, but in systems outside of health, which we all know, and as we're all seeing, really impact our health and well-being in profound ways. One of the cracks being exposed is how our health system accounts for racism, how our health system accounts for racialized folks, Black folks, Indigenous folks. I think today's conversation really is about race-based data, but our speakers, who you can see on your screen right now, will be extending that conversation. They'll be sharing with us how they think about race-based data, why they think it's important, how they think we should actually go about collecting this information, and ultimately what do we do with it at the end of it. So what do institutions and governments do with all this data? It's a pleasure to spend this time with our four guests. Giovanni Dappa Hosang, who has recently worked with Vancouver City Council, city councillors to pass motions and collecting race-based data in BC. He has a long history of being a student grassroots community organizer, and is a recent graduate from SFU. Great to have you here.
Greetings, thanks for having me, everyone. Yes, I was involved with Simon Fraser Students Society, as well as the Students of Caribbean and African Ancestry on campus. But I'm here now as an organizer with the Black and BC Mutual Aid for COVID, where we have started to give micro grants directly to the Black community here. But happy to be here.
Thank you. Also joining us is Dr. Sana Sharan, who is with the School of Nursing at the Faculty of Health and Social Development at UBC's Okanagan campus. Sana is also a health equity scholar with Interior Health Population and Public Health Department. I have the pleasure of knowing Sana through some work. Sana also sits on the board of the National Collaborative Center for Determinants of Health, and we've been working together on some really interesting projects which are very in line with today's conversation. So Sana will be bringing that to today's conversation. Also joining us is Sane Dube. So we have 4 S's on the line. We'll try and keep everyone, we'll try and distinguish between all the S's as we go through. Sane Dube is a policy and government relations lead with a focus on Black health, the Alliance for Healthy Communities. And the Alliance for Healthy Communities is an organization which brings together community health centers and Aboriginal health centers in the Ontario context. Sane has really been one of the leading voices in Ontario calling for not just a collection of race-based data, but for the improvement of Black health in general. A real pleasure to have you here. Sane and I sit on, we spent some time in some spaces, so we had a nice chat yesterday too. So really glad you're joining today's conversation. Our last
Thanks for having me.
Excellent. Our last panelist is Dr. Shannon Mcdonald, who's the Chief Medical Officer of Health for the First Nations Health Authority in BC. I often think about First Nations Health Authority as this really great model of what a vision for Indigenous self-determination in the health system could possibly look like. So Shannon, really thrilled that you are here sharing your experiences with us. And her organization has done a lot of work thinking about data governance, which again we'll be hearing about in today's conversation. So I'm going to get us started here. We're just going to get right into it. I think, Jill, we're going to start with you. So one of the big questions I think a lot of folks have is really, what does data do? Right. So why is collecting race-based data in the health system an important thing? What does that data do for us?
Right. Hi, everyone. So I'll tell you a little bit about what data can do and what from the experiences that I've had amidst COVID, and how we started to try and find data. So basically, we started around March, the end of March, starting to look into, okay, how can we really look into trying to give back directly to the Black communities, because we know that health inequities are rampant through various studies, through the various reports, and through various qualitative research studies that have been done. And we started to look into, okay, where can we do the research, because we want to, make sure that people who are negatively affected by COVID in the Black community, especially those in the gig economy, immigration status or precarious immigration status, or who don't have access to the resources that are put out there by the government. But we realized that there was a lack of this data, a lack of understanding of the scope in BC where Black folks are, or if any research has been done at all about the disproportionate impacts. But when we look in the States or looked at data in the States, we realized that folks were disproportionately impacted through the death rates. And even when we look at Ontario, we saw that they have started, a big push on collecting race-based data, and we realized that this was not here in BC at all. And the why is very important, because this is something that we can get to see the trends that happen over time if we start looking at the data more directly, because what we found that when Black folks, or when qualitative data has been put in place, we see that Black women, for example, have a higher risk of getting higher risk of getting breast cancer than white women in Canadian society. Or when we look at other research that shows that for example, in VPD report that, Black folks and Indigenous folks are stopped by police much more rampant. We need to see how this is permeated in the health sector. And I think collecting race-based data is a way to take those anecdotal experiences or qualitative research studies and try to make it across the sector, so that we are able to really understand what's happening. So what we did was realize, and in one of the studies we found a report called a Healthy City Scholar Report, towards a healthy city, addressing anti-Black racism in Canada, and realized that these calls have been made by communities. And we started to, push for race-based data, writing calls to the city. And we worked with Jean Swanson and Christine Boyle and some other folks to get a motion at the city council to really address this. Because if we can't even have an understanding of what's happening, then there will not be a means of redress that we actually should. We can't redress something if we don't know it exists. And it's kind of sad that we do need this data for redress that happens, and a recognition of anti-Black racism, or specifically here in Canada. But I think that's a good first step. It's no way a panacea, but this is the reason why we kind of need to start collecting race-based data, so that we can properly assess and then move towards redress.
Right. Thank you so much for that, Joe. I think you're raising some really critical points about the importance of data in supporting communities really to advocate for their own needs, and right, because oftentimes the system does demand that you have the information to prove that racism does exist, even though we know that there are existing reports and existing calls. When we get to the plenary part of our conversation, I'd like us to come back to you and have you just talk about your experiences working with city councils, because I think there's a lot folks on the line can learn for people who are trying to do similar things in their own context. So just percolate on that a little bit and we'll come back. Sane, Gio just hinted to some what the work which is going on in Ontario, which I know you've been very actively involved in. Can you just share with us some of what you're doing and why you think race-based data is an important part of it? And as you start to comment, I know you have some thoughts about how that data should be collected, particularly the role communities play.
Mm-hmm. Yeah, so thank you so much. And thank you, Joe, as well for your comments. So I think that the important thing to know is that these calls for race-based data are not new. This is something people have been asking for literally for decades. In Ontario, in about 2017, other sectors that were not health started collecting this data. So you found that education had started collecting it, the justice system had started collecting it, but there was a hold at that time on collecting health-based data, and that was partly because of some privacy issues that existed or that was cited at that time. So I think in all the time that people have been calling for this data, they had said that the data is useful because it helps us to better understand what is going on, which is something that Gio has talked about as well. And conversations we're having in Ontario recently are also saying that we have to pay attention to that. The data itself is not the end goal. The collecting the data does not deal with the systemic racism. Sumaya started her talk by talking very much about the systemic and structural racism that exists in this country. Collecting data is not going to change that. That's not the end goal. The data really should help us to put policies and systems in place that dismantle these oppressive structures, that ensure that they continue to be inequitable gaps. So I think what's been done in Ontario is that these calls have been going for a long time, and just given what we were seeing under COVID, the disparities that were emerging under COVID, and the disproportionate impact of the virus on certain communities, that created a context where we had a bit of a window and we could gain some momentum in asking for this data. So the province of Ontario has now said that they will start collecting the data. Some regions, for example, Toronto, where I live, they're already collecting this data in Toronto, and we'll start to see other people collecting the data too. But what we're also having now is conversations about, okay, you've said that you'll collect the data, but what does it mean to actually use that data for change? And then as Sumaya had hinted as well, we are having conversations very much about how do we think about accountability for the good use of that data, so that when that data is coming out, it doesn't further stigmatize or harm already marginalized communities. How can that data be used in a responsible way? We're also having lots of conversations about where is that data housed? Is it accessible to the communities who have been asking for it, or is it only going to be accessible to researchers and government bodies? So I think that it's definitely something we've advocated for, but it must also come with a conversation about what does responsible use of that data look like. And I'll stop there.
Great, thank you so much for that, Sani. The idea of responsible use, Shannon, I'm sure you have lots of thoughts about it, because I'm familiar with the data governance work which you're doing in your organization, which obviously builds on a long history of conversations throughout data governance, data sovereignty for Indigenous people. So I'm just going to pass it on to you to share a bit about why you think this data is important and a bit of your experience trying to do this. I know for within the First Nations Health Authority, but also in other spaces.
There we go. There's a bit of a delay, so it's confusing. I have been doing this work for like 30 years. And historically, data control was held in the name of the oppressor. Oh, I have to change this. It's very distracting. Why is that not working? Data had been used to dehumanize Indigenous people and to support racism and to support the institutions that left Indigenous people in a deficit in many, many ways, and was used to support the thinking about First Nations people not being able or having the capacity to take care of their own lives. Self-determination is a process, and it's been building over time. 10 years ago, as the First Nations and Health Authority was coming into being, we negotiated an agreement with the federal government about the control of the identity of First Nations people within government data sets. The concept of First Nations health information governance, guided by the needs and interests of First Nations people. Action focused. What can we do? Not an academic focus, because historically, academics have made their lives about describing the deficits that they ascribe to First Nations people, without ascribing those deficits to the institutional structures that create them. We need to work in a participatory way with our communities. We need to celebrate the resilience of communities and the strengths. Recently, we were able to say that First Nations in the BC had been impacted differently by COVID, but in a good way. That our nations had been less impacted by the virus than the communities around them. The First Nations client file and our information governance process not only gives access to information and voice to the communities and the nations, but it also allows us to demand accountability from those with whom we work. So thank you.
Thank you so much, Shannon. This idea of accountability has been a big part in the conversation. And I think you're making really good points about how we can use data in very different ways. So you can use data to build communities, or you can use data to harm communities. And I think a lot of the work which all the folks on all our speakers are doing here today is about really how do we use data to transform systems? How do we use data to improve the health and well-being of communities? So thank you. Sad, I think this is a really great place for you to get in. Shannon started to hint at the fact that the data conversations really focus on stigmatizing and dehumanizing communities, and we don't pay enough attention to the systems which create harm. So how do we, well, first off, why do you think this is an important conversation? Why do we need race-based data? And in addition to that, how do we start to turn our gaze on the systems? Like, how do we start to measure the systems which actually create harm?
Great, thanks, Sume. I just wanted to acknowledge before I start that I'm joining you from the ancestral, traditional, and unceded territory of the Silk Nation and the Okanagan. And I think it's a really important conversation, because one of the challenges I find, especially with the health system and the fact that they will by and large be the people with access to this data, is at least my experience working very closely with the BC health system is you can't really even convince people that data is not neutral. So there's this underlying assumption that data is quantitative information, it's just presented, it doesn't say anything, there are no choices to be made about how and what we present. And just getting people to start really peeling back the onion of everything we do when it comes to data is a choice. You can't just measure something and it magically appears in a table and it doesn't say anything. It's something that is really challenging, even when we're thinking about in the BC health system, like medical health officer reports. Often when you read those reports, they tend to sort of lean themselves towards neutrality, and having the discussions that there's nothing neutral about data is what we need to be doing, I think, with everything that we do. And so one of the projects that Sume had mentioned, that we were looking at the overdose data and how that data has been presented. And so working with the people who actually use this data day to day, when we did workshops, it took hours in a workshop to look at just a one-page statement that comes out of the BC CDC that tells you sort of, it measures the different things around the overdose crisis. And it takes hours to sit there and actually unpack what's being said in this, because it's not benign. The things that they've chosen to put into this report actually impact every level of the health system, every level of the response, and what's not there is as important as what is there. And so thinking through, if we're going to have race-based data, which we absolutely need, what is the complementary training that's going to be happening in the health system? What is the complementary work that's going to be happening to decolonize the health system, and at least bring people's consciousness up to the level that what we do and how we choose to use data is impactful. And it's based on a lot of, like you had mentioned at the beginning, Sume, a lot of assumptions that we don't usually bring forward, to the fact that we're living in patriarchal, white supremacist, colonial systems that actually dictate how we decide to bring data and problems forward. And so thinking about where that data is disseminated and how we can support turning the gaze away from measuring race-based data, but actually measuring the impact of the system. So if we're gonna present race-based data, then we better also have some indicators that show how those people or populations are interacting with the system, and how the institutions can or cannot cause harm. And so one of my major concerns about sort of race-based data is that it's moving forward, but we also need to be moving forward with all sorts of supportive training and support that can actually create, sorry, I'm not supposed to read the chat while I'm talking because of exactly what just happened, so I'm not gonna read it. And I lost my train of thought. Basically, my point is that we don't have a good understanding in general in the health system in BC or Canada, and you can see that in all of our reports, that there are structural and institutionalized determinants of health. And so I'm hopeful that as we're moving forward in this work, that we are able to provide support, training, and a different lens to that data, to make sure that we're keeping in mind that it's not people that are the problem, but actually the structures that are in place and how we can build that into data reporting, which is sorely missing at the moment.
Great, thank you for those comments. And I think my experience working, Sana, my experience working with folks across the country, I think really echoes a lot of what you and the other presenters have been saying about the health system's capacity to actually not only collect race-based data, but use it appropriately and use it in ways which don't harm communities. And I think it's a really perfect question. There's a question coming in from a participant, which I'm going to throw out there, and anyone is welcome to respond to it. The question is, given that institutions are the source of racism, why are communities asking them to be the ones to collect and be the stewards of that race-based data? So given that institutions, including health, are inherently racist, really, in the way they operate, why are communities demanding that these institutions collect data and be the stewards of this data? It's a two-part question, which, you want to start out
Actually,
there?
go ahead, Sani, because you're working on this regularly.
Okay, it's not a solid answer. It's more of an agreement that, yeah, this is actually, it's a very good question, and it's something that many people are asking, many people are concerned about. And I think it is something that we should be concerned about, because we know that all of these institutions are not free of racism. They were built with racism and with the oppression and marginalization of certain groups at their core. So Indigenous folks know this, Black folks know this, folks who belong to other groups know this as well. So it's a very good question. And I think that this partly goes back again to the that when we ask for data, we also need to be smart about thinking about where that data is held, how it's used, and how people are accountable in its use. So I think that's one way to deal with it. But I don't have an answer. I think I would just say that this was a good question. Shana, I'll hand over to you. Maybe you have a better reflection.
Yeah, so I don't have a good answer either, but I was thinking about, and there's diverse calls, I think, for race-based data. It's not one group calling for it to be done in one way. I know that, as Sana had mentioned, this has been happening for decades with different movements. I think these are just some examples of how it's being collected. But I do know that there is a strong movement towards community involved and community informed data collection. And so one project that I'm working on right now is we're calling it the BC CoLab. It's a population health observatory for substance use. And it is specifically community driven. And so the different community groups are deciding which data is collected, how it's used, and then that data is actually being fed back to the health system. So it's not the health system that's collecting it, but it is being sent back to the health system for hopefully action along with some directives. And so I think that's the piece that's really important, is that it's not just you send data, but you also send interpretation, because I do see someone is commenting that the data is the data. And so I guess where I'm coming from is that the data is based on what question you ask, and who's asking the question, and then the interpretation of it. And so to suggest that it can exist in a vacuum, I'm not sure is actually practically true. And so community, I think, needs to be involved in every step of the way, especially the interpretation and the piece of why that data is important to begin with. Because we often see, especially with Indigenous health data, like if we think of the example of FASD data for the last however many years since they started measuring it, it's actually completely misleading and false the way FASD has been characterized. And it's been because the people who are doing the interpretation don't actually have any real understanding of what's going on in the communities. And so having community lead the work, I think, is absolutely important, rather than having the institutions themselves sort of be in some bubble where they're collecting, interpreting, and analyzing the data.
Yeah, because these institutions don't have the background that they need. So yeah, I think I would agree with you that communities must decide or must be involved in that decision making about what goes forward, and particularly the interpretation. The interpretation is where so much violence happens. So it's necessary to have communities in that interpretation.
Great, thanks to you both. And Shannon, off to you. I think you have a comment you want to make here. You just need to wait a few seconds and unmute yourself, because we can't hear you yet.
My apologies. Technology is being a challenge. I'm getting an echo every time I speak. The Ministry of Health holds an enormous amount of power in the context of our work. They have the data sets of how healthcare is accessed, for what, and by whom. They also have the funding to have the capacity to do the epidemiological work. And in our case, they also house the First Nations client file, which identifies every status First Nations person resident in BC. So whenever we want to do a linkage exercise to understand how the health system impacts our population and our population uses the health system, we're trapped. We have to ask, beg often, that the resources of the ministry be brought to bear, and we have to negotiate around those analysis pieces. We have more and more champions who work within those systems, but there's still a huge power differential about how that information is collected and how we can access it.
Yeah, if I may jump in for a little, I think these institutions are inherently harmful, but they yield a lot of power to harm, and they are harming us right now in the absence of the data. And what some of these concerns are, I think we need to find out how we mitigate some of the risks when we do call for these same institutions to collect data, which is like co-ownership of data, making sure that, racialized critical race researchers are working within these institutions and doing that type of interpretation and, to mitigate some of those risks. So like, this is one of the biggest questions that have come up while we have been calling for it, like from community members itself. It's like, oh, but when they do, they're going to cause harm anyway. But no, it's a time to find out what other methods are there to make sure that community is involved, and the researchers are led, or the research is led by us as well.
Brilliant. Thanks all of you for those observations. And I think just to add to that, right? If we think about this country as a place in which we all share and we all have these rights and responsibilities, I think communities actually have a right to demand of the institutions which are supposed to be protecting us, because the health system at its core is not supposed to be harming people, even though we know it does. It harms Black folks, Indigenous folks, racialized folks, pretty much folks at the margins, and we see that consistently. So I think what communities are doing is calling for institutions to be responsible and to provide the same courtesy the systems provide to most white folks, not all white folks, because those issues exist, but really to provide the folks which I always tell myself, right? I think what people are demanding is that communities get treated like, the richest white guy will get treated. And that, it sounds a bit facetious, but it is true, because we know that health systems, even in the absence of the data, are making constant decisions of how they provide care, who they provide care to, and in what form. Human beings, we're very good at actually categorizing people. So even when the data is not there, those decisions are still being made in very active ways, particularly. And so the data is really around, I think, calling for some accountability. So part of the question also, I think I'd like our participants, everyone in the room, to reflect on is, why is there a resistance to collect this information? Right? Why do systems not want to be held to account? And also around, when we claims of neutrality, I would say are, because I think that has come up in the context of the data is just the data. Claims of neutrality are a significant way in which whiteness reproduces itself, because it says the system is neutral, even though we know that the ways in which systems respond to people are very different based on race, ethnicity, gender, class, and a whole host of other things. So thank you for those comments. There are a few questions coming in, which I think will just get our speakers to continue to respond to. There's a question which I just want us to go back to, and this is around community labor. So I'm just going to read the second part of it. So this is this idea that community does the work and then sends the information into the health system. And I think there are different versions of this. So really the extent to which the health system calls on community, because it doesn't have the capacity, which a number of you have spoken to do work for it. Have any of you on the line had some experience with this, and how are you navigating those challenges, particularly around really shifting towards community-led responses? Are we just downloading health system responsibilities then?
Sume, I can provide a comment on that. It's a big problem. We're seeing it with the SPORE initiative, the strategy for patient-oriented research, that has been basically reinventing community-based and participatory research, but in the healthcare and clinical setting, as if it's something new. And it doesn't take that long to go to those events and realize that the patients that are participating are predominantly affluent or predominantly white, and are predominantly used to having their voices centered and are able to participate. And I'm not trying to discount from their contributions. But the reality is that patient-oriented research in general is not resourced or created in a way that actually allows the meaningful participation of voices that are usually excluded. And that's because there usually isn't enough compensation. There isn't attention placed in how to create safe spaces. A lot of the people who need to have their voices heard and included don't have the time to go to these middle of the day hours and hours meetings. And so you end up usually with people who are retired or who have the means to participate. And I do think we need everybody's voices, and there's a place and a time for people's voices. But when you think about compounding risks and marginalization, it becomes a really big problem when we're thinking about the labor of people. The one way, obviously I'm a researcher, the one way we've been able to work around it is we do get grants and we get research budgets. And so then we have money to allocate and compensate people, but it's not perfect. We usually have to fight for the compensation level that we're providing people, and we have to remind people that somebody's expertise is just as valuable, if not more valuable in certain contexts than our own. And so it is an uphill battle, especially also when you're working with Indigenous partners. Often you can't easily reimburse people with the university systems and payment systems. So it is something that absolutely needs to be addressed, and a lot of attention needs to be put there, as opposed to sort of tokenism and demanding free labor of people. So it is an ongoing challenge.
Great, thank you for that. I'm wondering if our other speakers have some thoughts about this question. If not, we'll go to another one and then some final thoughts from all of you. No?
And I'm thinking about, so something that we're starting to see more of in Ontario, we've seen this where communities are creating their own protocols around how to engage them around research, and even how with the collection of data. So I think I agree with Sana in saying that it requires a lot of intentional reworking of systems that have existed for a long time. But I don't think that we have something that's prescriptive. I really think that a lot of those times it needs to be something, again, that's done in consultation with the folks who are developing it. But I do think, I don't have an answer. All to say, I see the concern.
The other concern for me has to do with credential creep and whose knowledge has value. That we often hear from our elders who are invited to meetings in a token way, but never really have the information they bring be valued, their experience, their history, that the anthropologist or epidemiologist or other scientific person of knowledge and paper is valued in a much higher way in those contexts. And it makes it really challenging for the messages that are really required by the community to come to the surface.
Great, thank you for that, Shannon. I think it definitely reflects the experiences lots of communities have when you're invited into spaces like that. And really, I think it's a challenge not just around data, but really around community engagement and community involvement, the extent to which community voices actually shift decisions, as opposed to be a check exercise with decisions made before folks get into the room. So I think that's a really good point for us to get some final thoughts from all speakers. So I'm going to invite you all to share. Imagine we're in a perfect world. We're in this little utopia of us as in another world. What kinds of policies and programs will be in place? So we have all the data we need. What kinds of policies would that allow us to put in place? And so what does that look like? But before we do that, I think our conversation really, and this tension which we are playing around, which is, can health systems actually collect and use race-based data and really other equity-related data responsibly? I think what we're really calling for is to ask ourselves the question, what aspects of our beliefs, values, and knowledges do we need to disinherit, disavow, decenter, disrupt, and in addition, claim, reinsert, or center in order to do this work appropriately, right? Because I think we're all quite right in saying that the way systems are set up right now, they're not set up to do this work and to do this work in a responsible way, which is part of that broad call which folks are making. So with that, I'm going to pass it on to our speakers. One final thought, and let's skip to a minute each. Jill, we'll get started with you.
In a perfect world, what I want to see is one, some of these commitments that are being made now actually adhered to, and folks are being held accountable. That consultation and community involvement is done driving this work. But also the policies that we want to see in place are, some that really tackles a lot of these inequities at the core. So we already see data being collected as visible minority, but Black communities have been saying that this erases Blackness, or erases specific instances of, it erases trends that continuously happen with Black communities specifically. And we need more data, need more nuance, we need more we need more data to be able to know what's happening to our community specifically. And I think equity data around, addressing what has happened historically and what continues to happen today regarding anti-Black racism and anti-Black structural racism in all our sectors is the place that I want to see that we go to. Employment equity programs, social equity, health equity programs specifically for Black folks and other racialized communities as well.
Great, thank you. Sana, and Shannon.
Let's not all speak at once.
In that order.
Okay. I guess my final thought is it's been a really interesting time the last few months with global attention, at least in my lifetime, I've never seen on interest in and appetite for dismantling systems of oppression. One thing that I hope is going to come out of that, and I haven't actually quite seen it yet, is that all of us here on this call, all of us live and work in different circles and bring different privileges to the table. And so I'm hoping that there's going to be more space and safety and desire for people who want change to actually speak up in every circle and in every table that they're at, and not hopefully look to having the people who are most impacted by these issues having to always do the labor and the work. And so I just encourage everybody, send emails, ask questions, put the pressure on, because it's never been safer to do so. And in a lot of ways, a lot of us are a lot safer to do this work. And so if we can start taking up the work alongside the people who are impacted, I do think you don't have to have the answers. You don't have to know what the perfect outcome is to take action. So if you can't imagine where we're going, that's fine. We just need to be going somewhere that's better than today. And so if we can demand that and really stand sort of in the line of fire whenever we have the opportunity to raise those questions, I think that'll be a start. And hopefully slowly things will get better.
Thank you,
Sana. So I'll build on what Sana was saying. I think that I go back again to that if we collect this data must actually result in tangible outcomes, tangible improvements and changes to people's lives. And I think that a way of doing that is to use that data to create what are called health in all policies. So this is something that the World Health Organization came out with, I think about 2014. And it's the idea that like with whatever policy you're making, you need to consider how this will impact people's health. And so something as simple as in Ontario right now, we're talking about public transit in Toronto, possibly going up. And we know that the people who are impacted when transit goes up are people who are low income. And then that can also impact people's health, because it means that people are making cuts in other places so that they can get around. So something as simple as a policy around transit actually has a large ripple effect. So I would like to see the use of data to actually transform the ways that we make health policy and that we make policy in other sectors, so that we are really centering an approach that puts people's health first. And in so doing, we have a better commitment to actually reducing health inequities. And that's all for me.
There's just a few phrases that are really important in this work. One is recognition of the nationhood, the people, and their needs. The second is creative disruption. That's really our role in this, to be that voice. And I honor and respect the other people that have spoken. And the final one is something we use quite often in discussions with government, and that's the concept of reciprocal accountability. That we will be accountable to those that need us to be accountable, as long as those folks are accountable back to us. So thank you.
Great, thank you all so much. I think you have all really spoken to the importance of this issue, and I think in many ways raised some really interesting questions to go with it. I think the intent of today's conversation was to raise some of this pertinent issues in our minds and hopefully leave us all with a sense that this is important. It needs to be done in ways which are appropriate, and communities get to determine what that looks like in different contexts. And ultimately, this is about making real change in the lives of communities, and we're using communities to mean people, right? In the lives of real human beings. So that is the ultimate goal. So I'd just like to thank all the speakers for spending some time with us today, and just echoing, Shannon, your point there around creative disruption. It's really important. I think what starts to happen as we continue to have this conversation is not just in the health system, because similar conversations are happening in our personal lives, is it starts to, in a sense, the consciousness is being raised, right? So we need to leave space for that disruption to happen. If we want to see change, it cannot happen in our systems as they exist today, right? That is part of the message, I think, is our current systems are not designed for that. And so our current systems, we need to really, in those spaces, really need to think about how we divest from white supremacy ultimately, because that is really what is driving the racial inequities we see across Canada and really across the globe. So again, thank you to all our speakers for joining us. We had some great witnesses with us. Thank you. And to all our participants. We're going to end today's conversation in a slightly different way. But before we do that, Jen, I believe you have an announcement for all our speakers. So please, everyone, stay on. We are not done yet. But Jen, I'll pass it on to you.
Thank you, I do. We just want to invite you to next week's event, A Tale of Two Crises, COVID-19 and the Overdose Emergency, which will be also another exciting conversation, building on our conversations on health. Sumi, I am aware that we are very close on the end of our time. And I'm wondering if we just leave it for breakouts so that the witnesses could share with whomever is in their breakout what they are taking away from the conversation, rather than what we were talking about having everyone share. I do want people to acknowledge that we have Vancouver Foundation, we have Michael Smith, we have hospital and folks in that room, and I would like to honor what they have brought and committed to share that in our breakouts, to let us depart in a good way.
Great, thank you. I think that is a great idea. So we're now going to go into breakout sessions. You all get into a group, and in your group, there'll be a witness who, as Jen mentioned, will share what they are taking from today's conversation. So please feel free to engage with them, ask them questions with the time we have left. Thanks again to everyone for joining us today, and we'll see you all in the breakout rooms. A couple of our speakers are going to stick around, so you may see them in those rooms with you. Thanks to today's organizers for today's conversation.